The topic we're going to discuss today is another very important topic in the general surgery course. And this is one of the common emergency presentation, and especially when the patient is coming to you with severe abdominal pain, you suspect mesenteric ischemia. So we will be discussing about the mesenteric ischemia today. We'll be discussing in detail about the management of the acute mesenteric ischemia, but we'll be talking about chronic mesenteric ischemia as well. Before going into the details of the mesenteric ischemia, one thing you should know is, again, you have to go back to the anatomy, and what you need to understand is the division, which is the foregut, midgut, and the hindgut. And we know that if we talk about the foregut, so foregut is extending down from the esophagus down to the proximal duodenum. And from the proximal duodenum, the part of the distal duodenum till the mid-transverse colon, that's basically the midgut. And beyond the transverse colon till the rectum, the part is the hindgut. Why this demarcation is important? Because not only embryologically, probably the embryological origin is different. Plus, the blood supply of all these parts are different. So there's three important vessels which are supplying the most of the part of the gut, including the small and the large gut. And the three important vessels are celiac trunk, superior mesenteric artery, and the inferior mesenteric artery. So these vessels are directly originating from the descending abdominal aorta. And if we talk about the celiac trunk, so it's originating from the abdominal aorta at the level of T12. Superior mesenteric artery is arising at the level of L1, and inferior mesenteric artery is arising from the level of L2. Now, you need to remember that there are different various branches of the celiac trunk, which are all the way coming and supplying the stomach, pancreas, liver, and the foregut till the part of the proximal duodenum. And from the duodenojejunal flexure till the splenic flexure, you can say, or mid-transverse colon, the whole of the gut, that means midgut, that's supplied by the superior mesenteric artery. And from the splenic flexure down to the rectum, the supply is coming from the inferior mesenteric artery. Now, when we talk about the mesenteric ischemia, the most of the artery which is more vulnerable to ischemia is superior mesenteric artery, and it's directly originating from the abdominal aorta at the level of L1, and most of the blood supply of the mesenteric artery is to the midgut. So any problem or any occlusion of the superior mesenteric artery, either it's a thrombotic occlusion or it's an embolic occlusion, that will result in the compromise of the vasculature, or in the compromise that would be a compromise in the perfusion of the midgut. Now, you need to know that there are some, risk factors which are responsible for this presentation. And most of the time when we talk about the acute mesenteric ischemia, the cause is not a thrombosis, okay? Most of the time it's embolus. And embolus can arise most of the time, it's in the left atrium, and when the left atrium is in fibrillation, that means the patient is suffering from atrial fibrillation. So there's a propensity that any embolus will be dislodged from the left atrium because of the atrial fibrillation, and it will directly come down to the arterial distribution that most of the time is descending abdominal aorta, and it can struck anywhere in the origin of the superior mesenteric artery. Now, if the embolus is obstructing, or you can say occluding, the superior mesenteric artery at its origin, then obviously a vast portion of the gut would be affected. Like, most of the time it's from the DJ flexure to the splenic flexure. So most of the time, if the occlusion is at the level of the origin of the superior mesenteric artery, and if the occlusion is away from the origin, it's close to abdominal aorta, maybe in the branches most of the time, so it's middle colic artery which is affected. So only a limited or a small portion of the midgut would be affected, anywhere from the flexure to the mid-transverse colon. It's most of the time it's a middle colic artery which is being affected. Now, when you talk about the causes behind this particular disease, you should remember that most of the time the emboli, they are originating from the heart. So any patient which is suffering from particular heart disease, like valvular diseases, like valve agitations, atrial fibrillation, or mural thrombosis in the left ventricle of the heart. So these are the multiple risk factors which can actually develop because there's a source of thrombus, okay? And source of the thrombus is because of the pathology in the heart. So emboli will get disrupted from that particular part of the heart, and it can lodge anywhere in the distribution of the superior mesenteric artery. Now, another important thing to know here is the process of atherosclerosis, okay? Because sometimes there is aortic aneurysm, and in aortic aneurysm there is atheroma formation, and that atheroma, or you can say the atheromatous plaque, that is disrupted, and it's basically leading to the occlusion of SMA. Now, when you talk about a generalized atherosclerosis, or when you talk about the process of thrombosis or thrombogenesis, so most of the time when you talk about the acute presentation, so it's the embolus which is responsible for acute mesenteric ischemia. The thrombotic processes or thrombogenic processes secondarily to the atherosclerosis, that's because that result in a manifestation of the chronic mesenteric ischemias. Now, it can be arterial occlusion, or it can be venous occlusion, okay? Because we have a superior mesenteric artery and we have a superior mesenteric vein. So if there is a distribution if there is a embolus is occluding the superior mesenteric artery, then obviously there would be SMA occlusion, and immediately there would be hypoperfusion and necrosis of the gangrene. And if we talk about the venous occlusion, because whenever there is a venous occlusion, there is edema, and because of that edematous changes, the mesentery is edematous, and the bowel then become edematous, and then it's ultimately leading to the inflammation of the bowel, and then causing a particular necrosis and later on gangrene. Another important thing to know is about the causes for the superior mesenteric vein occlusion. So when we talk about the venous occlusion, there are some diseases like the portal hypertension, like liver diseases, like cirrhosis, and especially when you have sickle cell disease, and these are most of the connective tissue disorders. They can actually lead to the venous occlusion. Some vasculitic processes like thromboangiitis obliterans, this is one of the cause of superior mesenteric arterial occlusion as well. So remember, mesenteric ischemia can be with occlusion or without occlusion, okay? So by typically it means that there would be particular stenosis, maybe 90% of the stenosis of SMA, or there would be complete stenosis of SMA that would result in acute presentation of the symptoms. Okay, so we already talked about the acute condition and we talk about the chronic condition. There's a difference between acute and chronic depending upon their causes, depending upon their presentation, depending upon their symptoms, and also obviously their treatment would be a little different. And when you talk about acute mesenteric ischemias, the presentation is like severe, sudden onset of the abdominal pain. And sometimes if it's delayed in presentation, then the patient have these signs of generalized peritonitis. Now, when we talk about the chronic, so the patient suffers from sudden onset of the pain postprandial. That means whenever he is eating, so after eating within 30 to 60 minutes, he will develop an episode of pain, and it would be accompanied by weight loss, and malabsorption would be more pronounced in the chronic mesenteric ischemia as compared to the acute. So most of the time, this chronic is, the diagnosis, it's misdiagnosed because it's being misconcepted with, irritable bowel syndrome, and some people also consider this as a peptic ulcer disease. So actually, they are not definitive in their diagnosis, and when the diagnosis is missed, obviously the treatment and prognosis of the disease becomes bad. Plus, in case of the chronic mesenteric ischemia, it's also called as mesenteric angina, because whenever the patient eats something, whenever the patient is not taking anything, he's not eating, he's okay. But whenever he's taking food, so within 30 to 60 minutes, he develops an episode of severe abdominal pain that resolves on its own. So in case of chronic, the disease, the gradual onset of the pain is important. The word gradual is very important because in acute, it's a sudden onset, and in chronic, it's a gradual onset of the pain. Plus, in acute, most of the time, it's because of the disruption of the erythematous plaque, or it's because of, emboli, which are coming from the heart. But when you talk about the chronic, it can be as a result of diffuse atherosclerosis process, and because it can be because of some vasculitic changes, vasculitis as well, like thromboangiitis, obliterans, and some other causes. In acute, you have to be very vigilant, you have to resuscitate the patient, you have to save the bowel. But in chronic, the patient has already good well-defined collaterals, and these collaterals are actually maintaining the perfusion. And then you have to plan for a definitive management of such patients, like you have to go for a grafting. But in acute, you have to do the embolectomy, or you have to do the bowel resection, depending upon the necrosis and extent of the bowel involved. So that's the difference between acute and the chronic mesenteric ischemia. And acute is obviously the emergency, and you have to treat your patient as soon as possible. Okay, so this picture is very, very much important because it's actually telling you about the difference between the division in the thrombotic event and in the embolic event. So if you could appreciate here in the first diagram, you can see here that this is the part of this is actually the abdominal aorta, and abdominal aorta giving a lot of the branches, and this is actually the superior mesenteric vein. Okay, so this is the superior mesenteric vein, which is coming from this abdominal aorta. So at the level of L1 vertebrae. So we know that superior mesenteric has got number of branches, and this is the middle colic artery. So most of the time, these emboli, they lodge into the bifurcation, or you can say the part where the main trunk is branching into the middle colic artery. So you can see here that this is actually the part which is involved. And most of the time, it is the embolic occlusion, and it's occluding the superior mesenteric artery, and most of the time it's the division is more distal as compared to more proximal. So you can see the part of the middle colic, the branch of the middle colic is also affected. So whenever the main trunk is saved and there are occlusion of these small branches, a limited portion of the gut would be affected. But whenever the main trunk is affected, of the superior mesenteric artery, then obviously a large part of the gut would be affected, starting from the DJ flexure to the mid-transverse colon. So this is the second part, and you can see here actually that most of the time you can see that this is the proximal gut, and the proximal gut is most of the time saved whenever there's occlusion to the middle colic or more distal occlusion of the superior mesenteric artery. You can see here, this gut is the reddish color, this is viable, this is healthy gut, and you can see the gangrenous gut. So, the half of the gut is gangrenous and half of the gut is saved. But if you see here, as a result of thrombosis, okay, so more proximal part of the superior mesenteric artery is affected, or you can say the main trunk of the superior mesenteric artery is affected. And if this is involved, if the main trunk is affected as a result of diffuse atherosclerosis or thrombosis, then obviously you can see most of the gut would be affected, and like most of the small gut and mid-transverse colon till the mid-transverse colon. You can see this duodenal flexure, the splenic flexures, and you can see the mid-transverse colon, they're also affected, and the proximal duodenum, except the proximal duodenum, the distal part of the duodenum, then jejunum, then ileum, then most of the ascending colon, duodenal flexure till the mid-transverse colon, they are affected. If the origin or the main trunk of the superior mesenteric artery is affected. So that's why it's very important, and it's very important to early recognize acute mesenteric ischemia. Why this is important? Because if it will be prolonged, then a lot of, or you can say the more distal part of the gut would be involved, and then there would be edematous wall or secondarily to the hypoperfusion, and there would be release of the inflammatory mediators and cytokines and interleukins, and there would be bacterial and seeding, and there would be bleeding from the bowel, from the mesentery and from the bowel, and there would be peritoneal fluid, and the patient will develop diffuse peritonitis. So if you diagnose earlier, the prognosis is good. But if you, by the time the gangrene is developed and more extensive part of the gut is involved, the mortality ranges from 70 to 90%. So that's why it is important to diagnose this disease earlier and save the gut, because if you manage to open up your patient and you do the exploratory laparotomy, then what will happen that maybe a large part of the gut would be affected, and obviously it's not possible to resect the distal part of the duodenum till the mid-transverse colon, and the patient, obviously the post-operative or intraoperative mortality would be very much increased. So that's why early recognition is very, very much important in this disease.